Moving away from stroke volume, we're going to look at heart rate and how heart rate regulates cardiac output as well. Heart rate, remember, is determined by multiple factors, but it begins in the autorhythmic cells of the heart. As a reminder, those autorhythmic cells have an unstabilized membrane potential, and so we call this potential here that I'm coloring now in pink the pacemaker potential, and here we see it again over here on the other side. That pacemaker potential is due to a slow influx of sodium through the eye-funny channels. And then that will generate, of course, a depolarization, the opening of those voltage-gated calcium channels, giving us this rising phase. The voltage-gated calcium channels will close, and then we will get our falling phase through the movement of potassium through voltage-gated potassium channels. And so this is our standard pacemaker rhythm. Now the rhythm that is generated, so this, that we look at, the rhythm that is generated is going to be different depending on where our pacemakers are. In the sinus atrial node, all by itself, take it out of rip the heart out of the chest type of thing, so it's not talking to the nervous system, all by itself it's going to beat at 100 beats per minute, which means each of these depolarization events will occur 100 times every minute. The AV node, the rhythm is going to be 60 beats per minute approximately. So again, while the action potential will look the same in terms of shape, the frequency of that action potential will occur 60 times every minute, and the Purkinje fibers on average anywhere from 30 to 40, which I've got 40 written here. So again, same thing, this time only 40 times per minute we're going to get a depolarization event. That's the rhythm of the heart. Now, not surprisingly though, the sympathetic and parasympathetic nervous system affect this. So for the sympathetic nervous system, these are going to naturally increase heart rate. And they do that if we compare the pacemaker potential. So here's the original pacemaker potential that I'm coloring on in orange. And then because of the sympathetic nerve activity, so we're having action potentials being generated in the sympathetic nerve activity, they are stimulating the SA node, and they also would stimulate the AV node. And what they're actually doing is they're going to they alter that G protein coupled receptor activated by the norepinephrine or the epinephrine, alters the property of the eye-funny channels to make them more leaky to sodium. So the slow inward leak of sodium becomes a little bit faster. And that means we reach threshold sooner rather than later. And so, of course, at threshold, we're going to activate those voltage-gated calcium channels. And then during the falling phase, our voltage-gated potassium channels, allowing potassium to leave. But if you look at this figure that I've overlaid on top of the default graph, so to speak, you'll notice that our depolarization events are happening more often compared to, if we look at how long does it take for us to get a depolarization event under normal circumstances. Here's one, here's two. Now we're essentially getting, in the space of the one, we're now getting the two. So two of them squeezed into the original space. Any type of molecule that affects the time, not the strength of contraction, but the time, is called a chronotropic, chrono meaning time, chronotropic agent. And a positive chronotropic agent increases heart rate. So norepinephrine and epinephrine are both positive chronotropic agents. They bind to the beta-1 receptor. And again, these are our endogenous ligands. We do have medications that are also chronotropic that either intentionally or due to a side effect. And those chronotropic agents would be used, for example, to treat heart failure as one possibility, although the ionotropic agents would probably be better. The parasympathetic nervous system slows heart rate down, and it's going to do this by essentially having the opposite effect of the sympathetic nervous system. Instead of increasing membrane permeability to sodium, but oops, I think I copied and pasted and I should have changed it and I didn't. So let's change this now. We're going to rewrite this. The parasympathetic nervous system decreases, slows it down, the rhythm of those pacemaker cells by decreasing the membrane permeability to sodium. That's what I get for copying and pasting without double checking that I changed it. Anyway, so here's the correct sentence on this slide. The parasympathetic nervous system decreases the rhythm by decreasing membrane permeability to sodium. So again, we're resulting in modifications to that I-funny channel. So now it takes longer for the cell to reach threshold, which means in this case, if we compare, we're firing, here we would fire an action potential normally here versus here, but now as you can see, it takes longer. So instead of the original moment when we would fire the next action potential, we're firing it later in time, so chronotropic. So positive chronotropic increases the heart rate, whereas a negative chronotropic decreases the heart rate. Now we can get this endogenously through these muscarinic receptor agonists. So acetylcholine obviously is a muscarinic receptor agonist. And so that's, that's the standard chronotropic, negative chronotropic agent that will slow down the heart rate. But again, once again, we have medications, and actually in this case we have many different medications because we often want to regulate blood pressure by slowing down heart rate. And so we have medications to decrease heart rate, including many beta-adrenergic receptor antagonists, which if we consider that the beta-adrenergic receptor antagonist is an agonist is a positive chronotropic agent, so that norepinephrine and epinephrine are positive, and they bind to the beta-1 receptor. So if we prevent them from binding, then naturally we're going to slow down heart rate. So we have beta-1 receptor antagonists, and you'll sometimes hear them called beta blockers, and usually it refers to the beta-1 receptor, this beta blocker. Occasionally you'll have a beta blocker that hits both the beta-1 and the beta-2, but those aren't nearly as effective because, while yes, they'll speed up heart rate, they're also going to cause vasodilation. And so these are the ways we regulate heart rate, and heart rate, of course, regulates cardiac output. All right.